Sì, sì, grazie. Good afternoon. We are ready to start again. And Giovanna,
Yes, I am here. I am ready.
okay, if you are ready, you want to start with the complication in pediatric heminephrectomy. You are Giovanna and Mirko, please.
Yes, I try to share my screen.
Yes.
Yes, I will go up. So I want to, first of all, I want to thank the president, Darius Patkowski. I want to thank Mario Lima and all the good friends of the group, which who gives me the opportunity to give to me and Mirko the opportunity to present our paper. I will show you two cases, which are nice cases. One of them has also a complication, lower and upper heminephrectomy, and then I will go through the literature and the discussion about the complication of heminephrectomy and how to manage them. Sorry, I try to go on. Could you see my screen? I hope so. Mario, is it possible? Could you follow my screen?
Yes, yes, yes. Work. Well.
It's okay. First case that I will show the video was a patient who came to my outpatient clinic at 13 months of age. He had the prenatal diagnosis of bilateral venous dilation. At the 2 months, he has a febrile urinary infection. We performed the avoidance cystogram, which demonstrated no posterior urethral valves because it was a male, and a big reflux, 4-degree reflux in the lower moiety of, of both kidneys. So a severe 5-degree reflux in the low districts bilaterally. Then we moved to other investigations, such as an MRI, which is now the gold standard to study this complex uropathy. And as you can see, there are almost no parenchyma in the lower pole, a good parenchyma in the upper pole bilaterally. The MSR scintigraphy demonstrates absence of fixation of the radioisotope at the lower pole bilaterally, so they were not functioning. They were affected by severe reflux and with consequent urinary tract infection. So I decided to move to lower heminephrectomy, stage the lower heminephrectomy. First of all, the right and then the left. Right, I did a 4-focal technique because I used a 3 millimeter instrument to displace the liver. Generally, I like to do a right column mobilization to open the gerotta, and then the identification of the two ureter. As you can see here, there is the ureter of the lower pole. The ureter of the upper pole is well defined. And in the dissection, I try to stay very close to the ureter of the lower pole. Then, after the dissection of the lower stump, using an endoloop, we closed the lower stump, and then we move it back to the dissection of the pelvis. I like to interrupt sometime immediately the ureter in order to have a traction on the pelvis and also on the on the on the on the to facilitate the work. In this case, I identified the vessels. The vessel, well, as you have seen previously, closed, and then I decided to open the pelvis in order to be sure that no upper calyx of the lower pole retained in the dissection. In this way, the pelvis was smaller, and then it was easy to identify the right plane and to dissect completely the kidney without leaving any remnant of the urinary tract. Then we did the specimen was extracted through the 10 millimeter axon. This was a left side. On the left side, it was just a three-trocar procedure. That means it was not necessary to put another instrument. There are 1 3 millimeter and 1 5 millimeter for the ligature. Also, in this case, the dissection was very close to the adventitia of the ureter of the pelvis, in order to identify very clearly, as you can see quickly, the vessels, and to clean all the tissue in order to be able to isolate the vessel selectively. The vessels were not so big. I like to use the Maryland, and in this case it was enough to use the ligature to close the tributary vessels of the lower pole. Then we move it to the dissection of the ureter, and then I use the spaghetti maneuver to facilitate the to find the right plane. And as Olga showed it today, sometimes the calyx go deeply inside the remaining pole. And so it is very important to do this spaghetti maneuver in order to be able to dissect completely the calyx and not to leave any remnant of the urinary tract. And as you can see, this is parenchyma. There are no more urinary tract there. Sometimes I put some hemostatic agent, but I have to say it's not necessary after you have done this kind of dissection after the treatment of the tributary vessels. And then this is one of the arguments that we discuss later, how far we can go deep in the dissection. There is a moment where the wall between the two ureter is common, and it's difficult to go farther. And this can lead to the presence of a residual ureteric stump. This was the follow-up of this patient. If you can see, there are beautiful kidney, which looks quite normal bilaterally. But if you look to the to this voiding cystogram, in this case, there are not a lot on the left side, but on the right side there are a urethral stump that has to be followed. Till now, this patient, after 3 years, he has no infection, but it's possible that this stump will grow and it will be necessary to take away this stump. This was another case where, as you can see, the stump is really not so evident. This case was treated by Mirko and me. This was a patient, premature baby, 34 weeks of gestation, prenatal diagnosis of dilatation, severe dilatation of the pelvis and the ureter. Postnatally, we found a duplex collecting system, a suspicion of duplex collecting system. Avoid the cystogram, there was a reflux, a 3-degree reflux in the lower moiety, as you can see by the orientation of the pelvis. There were no ureterocele. At an MRI, the pelvis was the upper pole was completely represented by the pelvis, and the ureter was really very dilated. At scintigraphy, there was no function on the right upper pole, and so he underwent to upper pole nephrectomy. I have to say that there are some difference between the two procedures. In this case, the lower ureter was identified and put on a vascular lac, and then the big ureter tributary of the upper pole was dissected. It was the vessel well identified. Also, in this case, they were treated by ligature. At the end, there was a complete isolation of the moiety of the ureter, of the pelvis. And if you see, the ureter and the pelvis were passed below the vessels. This is quite important. Sometimes to cut the ureter could be help you in identifying the vessels, and especially if you're able to pass the ureter and the pelvis up to the vessels tributary of the lower moiety, as in this case. In this case, we put another kind of hemostatic agent. Then the ureter was completely dissected. In this case, the extent of the dissection was important, but not as in the case that I presented previously, because it was not refluxing, it was a stenotic ureter, and the reflux was in the lower pole and not in the upper pole. This was the postoperative course. If you can see, the kidney looks good. And this was the residual reflux in the lower pole that will be treated by deflux injection first. Then we will see. But I am quite confident that it can work, because the reflux is reduced after the heminephrectomy and also with the age. And moving to complication, I think this chapter was largely discussed today, gracias to the presentation of Paul Philippe and Olga Thiel. They posed the questions about complication well. But I think that the most severe complication is prolonged urine leakage. Urine leakage that can be treated by stent placement. That means double J, also single J. You know, the general urologists sometimes prefer to use a single J. And I used to put double J, but in my opinion, it's very important also to leave a vesical catheter and to put the vesical catheter in aspiration. In this way, there are quickly a resolution of the leakage. I had this experience also with leakage in UPJ syndrome. If you put an aspiration, the vesical catheter, the leakage will stop. In case of urinoma, the situation is certainly more complex, and I think we have to put two drainage, urethral stent and aspiration of the catheter, but also an abdominal drainage that can be put as a percutaneous ultrasound-guided pigtail, just not to be too invasive, and it generally works. Then we may have cyst at the level of tissue resection. They are reported in literature in about 25% of cases, so a big percentage. But this retention cyst disappears spontaneously generally. And this is reported in literature. I can show you also one case where the cyst was not a big cyst, disappeared completely. Another very important complication, in my opinion, more severe because it's not treatable, is the decrease in renal function. Decrease in renal function is reported from 2 to 6% of cases in literature, but decrease can be due to some ischemic damage due when produced during a non-proper dissection, identification of the tributary vessels, and also because sometimes we put the vessel under a vascular lack and then can give a damage, an indirect damage, if we maintain this compression for this suspension for a long time. Another question that can be discussed also is temperature. High temperature of the device that we use and also prolonged procedure can give some reduction in renal flow and can also contribute to the decreasing renal function. Then reflux in the urethral stump. If there are no urinary infection, I think we have to do nothing. But we have to follow this patient because if they are infection or if the stump will grow, we have to take away the stump. I had a case of a child that I treated by open upper heminephrectomy bilaterally for a Doppler's collecting system with upper pole not functioning. This patient came to visit me as an adolescent, and she had big stumps. At the beginning, the stumps were 1 centimeter, and the stump became iliac. So I took away the stump by robotic approach, and I have to say that it's possible to do this. Then this is not a complication, but is a problem that we may have, and we may to be front in case of heminephrectomy, and the problem is urinary incontinence. Urinary incontinence, especially when we are speaking about ectopic urethral or ectopic ureter. The ectopic ureter, which finish, as in this case, in the bladder neck or out of the bladder neck, can lead to urinary incontinence. In this case, is not a consequence of heminephrectomy, but heminephrectomy can treat the disease of not functioning pole, upper or lower pole, but it cannot solve the problem of urinary incontinence that remain open. My attitude is very conservative in this patient. I try to wait especially till adolescence, to invite people to do some rehabilitation of the pelvic floor, but I think that surgery for continence in this case is not, in my opinion, the first choice. Then if we move to the literature about the complication, this was an old paper of 10 years ago that I published with other colleague. There was the experience in retroperitoneoscopic heminephrectomy. Out of 50 cases, the incidence of complication was 14% with a high percentage of leakage. So not only Clavien 2, but also Clavien 3 complication. I have to say that I have not made any more retroperitoneal heminephrectomy, but I think that the right way to do an heminephrectomy is laparoscopic or robotic heminephrectomy. That means through the abdomen and not through the retroperitoneum. Another important contribution is made by the use of indocyanine green fluorescence that can be very useful in the identification of the anatomy, especially in lower pole heminephrectomy, but also when we do a nephron-sparing surgery for tumor. So this is another tool that we can have in MIS surgery for kidney today, but also for other procedure. Then I want to underline this recent paper which did a comparison between robotic, laparoscopic, and open surgery for heminephrectomy. And if you look to the complication, the number of complications was not so small, was the same, was comparable in the three series, open, laparoscopic, and robotics, but they found 55% of cyst self-limited, then 13% of urinoma, and also from 2.7 to 4.6 reduction in renal function. So that are the most important complications that we have to face. Cysts are considered not a complication. This was a case where I had a cyst at the upper pole. It was an upper pole heminephrectomy, and then the cyst disappeared quickly. So it seems very common, and he has to be followed, but it will solve spontaneously in the majority of cases. And I want to show also this paper published by our friend Darius, where they found also almost the same incidence of complication reported in the previous literature. So about 12% of prolonged urinary leakage and less than 6% of reduced function. So the complications are almost the same. And they have a recurrent urinary tract infection just only in one case. So that means that the stump was, they were not a long urethral stump in this series. Then I want to show this paper about not heminephrectomy, but about nephron-sparing surgery in Wills tumor. And this was a systematic review of 1,087 cases. So that means really a big systematic review. At the end, they considered just 45 patients, and that underwent unilateral renal sparing surgery and 25 bilateral renal sparing surgery for bilateral WIMS. And long-rank analysis demonstrated that cancer-specific survival was not significantly different between unilateral and bilateral nephron-sparing surgery or radical nephrectomy. This is very important to push to nephron-sparing surgery also in tumor. Obviously, it's possible in selected cases, in cases who underwent to chemotherapy, who had a good response to chemotherapy, to bilateral cases as it was always in the past. And in my opinion, can say that the best the most performant technique is certainly the robotic approach, because with robotic approach you have a better performance in terms of tissue resection, tissue sparing surgery, rather than in laparoscopy. Then I want to finish with this paper published by the European Association of Urology that invite to implement the standardized criteria in the assessment of complication after robotic partial nephrectomy. Why? Why? Because to perform the guidelines, as someone of the participants today asked for, we need to register the case. We need to register the complication, and we need to be able to standardize better the technique and also the technique useful to treat this complication. And this is just an invitation to register the patient in order to be able to do a better standardized criteria and a better standardized advice. Thank you very much. I have finished. If there are any questions, I am available for.
Thank you very much, Giovanna. There is question from the audience. I don't see question in the chat. Okay. Giovanna, if you remove your screen.
Yes.
I'm sorry, I just want to remember that it's very difficult to follow this patient also, and also to ask to all the to talk and discuss complication. I remember we made in the dead group of that was before we made an app with for a special to look at all the complication of laparoscopy, but no one was participating at that. I agree with you, Giovanna, that it's very important. It's very important also the guideline would be reached definitely also in this kind of surgery. Thank you for your suggestion. Sorry, just it's a very, very good point, this one.
Thank you, Alfonso. But you know, the is just to follow what Ernica tried to do for other pathology. The first step is to do a registration of the case, because only doing the registration of the case, following the case through the year, you can know the complication. And you can also you can be able to standardize how to manage this complication, also about the experience that emerge. Otherwise, it's difficult to have this number or this information, as you said.
I want to stress what you say, Giovanna. If you have a leakage, it's very important to put in aspiration of the bladder. Because if you don't put in aspiration the bladder, you don't have good results, but have a problem. Yes. And now, if there is no question from the audience, I call Tommaso Gargano that speak about the technical details of robotic heminephrectomy. Gargano, you all ready?
Yes. Good afternoon.
Good afternoon.
One moment. You see my laptop, my presentation?
Yes.
It's okay. Good afternoon, everyone. Thanks you for your kind invitation. I'm going to present to report the technical aspect and the surgical technical details regarding the robot-assisted laparoscopic partial nephrectomy, in particular in duplex system. The main indication in children for the robotic-assisted laparoscopic partial nephrectomy is a duplex system. This is with a non-functioning moiety. This is a condition more common in girls and usually present with recurrent urinary tract infections associated to ureterocele and may present with continuous dribbling of urine pseudoincontinence when the upper moiety ureter is inserted into the urethra, for example. Regarding the preoperative workup, the preparative workup consists of renal ultrasound that allow to evaluate the eventually hydronephrosis, the parenchymal thicknesses, ureteral dilatation and tortuosity, and eventually ureteral insertion if ectopic. The DMSA or DMTA renal scan in order to confirm the silent of function of the involute segment, the involute moiety. The MRI urogram and the CT urogram that will provide the anatomical detail and allow to confirm the ultrasound findings. Regarding the preparation of the robotic procedure, it's very important the compression of the colon with enema performed the night before, the intravenous antibiotic, and some authors suggest the placement of a ureteral stent before to robotic assisted laparoscopic surgery to better identify the normal ureter. Regarding the approach, we saw this morning with a nice presentation of Professor Philippe. We prefer the transperitoneal approach. Why? Because in this approach, the anatomy is more familiar. The working space is more large, and the eventually possibility to perform concurrent procedures such as extravesical ureteral reimplantation, like a minimal invasive leash gregoire. Regarding now the preoperative technical aspects, the room setup and the patient positioning are exactly the same of a complete nephrectomy. In particular, the patient is placed in the modified flank position, 30-45 lateral decubitus, and the patient is placed on ergonomic BM bag before desufflated and then insufflated to cover the articulation with the padded in the pressure points. In this case of the surgeries in the left side, the left arm is placed straight down the patient's side. This to avoid the injuries during the movements of the robotic arms. The safety straps are placed to cover the head, the shoulder of the patient, the pelvis, and the lower extremities in order to prevent injuries when tilting the table. Regarding the access, should be very large from the renal area, renal loggia, until pelvic cavity to excise the affected ureter. We put always the Foley catheter inside. We use, in order to have good access, we use are placed one 8mm umbilical camera pores and at least 3 others accessory trocar, 2 robotic and 1 laparoscopic port. In particular, you can see the robotic ports, one in epigastric zone, one in umbilical for the camera, and one just above of the iliac crest in the midline clavicular line. The accessory port is placed between the last trocar. We suggest to bring the patient towards the edge of the table and rotated off the vertical plane. This maneuver allows and prevents the robotic arms from colliding with the table. Now you can see the position of the trocar, in particular the distance, the minimal distance between the robotic trocar, at least 6 centimeters. And another thing very important is the right position of remote center inside to the abdominal wall. In fact, to ensure the good maneuverability and a lot of freedom of degrees. This position, this setup, this alignment allow the robotic arms to be in optimal location for a good functioning. And it is important, especially in younger children, to lift the ports and the robotic arms upwards and outward from the abdominal wall to maximize the working space available inside the abdomen, the instruments to maneuver. The slide, you can see the schematic picture that show the operative room setup with you see the surgeon seated seated in the console, the assistant surgeon in front to the patient with a robotic system behind of the patient with a control tower, and you can see the position of the anesthesiologist and the scrub nurse. Before the docking are mandatory the preselection of the anatomic distract, in particular in this case the kidney, and the approaching of the robotic system at the shoulder of the patient in this case, and the targeting addressed in this case in in robotic camera ports. The docking, when the robotic system is docked, don't forget the table movements are provided in order to avoid the injuries and lesion at the patient due to the force of the robotic arms. Regarding the instruments that we use are the Maryland bipolar forceps, generally for hands, for the left hands, and the monopolar curved diathermic scissors in right hand. We use through the accessory port, 5mm accessory port, the clip appliers, 5mm clip appliers, the endoloop or a needle holder for the ligature, and irrigation suction. Regarding the pressure and the flow of the pneumoperitoneum, varies according to the size of the patient, but generally the range are 8-12 mm of mercury regarding the pressure, and 1-2 liter minutes regarding the flows. Now I describe step by step the surgical technical details. The access to the renal loggia. It's important in this case the mobilization of, in this case the surgery in the left side of the splenic colon, the splenic flexure, and it's necessary to carry the dissection along the white line of Tolls. to open the posterior peritoneum. And once the Gerota's fascia has been incised, the dissection can proceed to expose the anteromedial surface of the left kidney until renal hilum, identifying the hilum. It's often difficult to visualize the renal hilum and the hilum of the both moieties due to the surrounding fat tissue. So we suggest to identify before both the ureters and to advance the dissection superiorly towards the renal hilum. So it's important to trace the ureters before and follow them to their until to corresponding renal moieties. The ureter of the dilated ureter of the affected moiety is skeletonized, preserving whole vascular adventitia on the ureter draining the normal moiety. And the distal ureteric stump should be removed as far distally as possible. But as we saw this morning in the wonderful presentation of Professor Philippe, Professor Patkowski, and so on. The next step is the management of the blood supply of the upper moiety. In fact, you can see the isolation of the artery, the vein, and in particular the vessels are individually identified, ligated, isolated, ligated, clipped, and after divided. In case or a non-functioning upper pole system, the upper pole ureter should be dissected free from the surrounding tissue and then divided. The proximal ureteral stump is then, after gently passed below the lower pole renal hilum, and then this is regrabbed and pull up from above. This maneuver allow and help for a better dissection of the upper pole hilum and for the hemostasis of the posterior part of the upper moiety. If the condition is due to an obstructive process, the remnant ureteral stump should be left open. If the condition is due to the vesico-ureteral reflux, as this morning they said, the remnant ureter should be ligated, in this case by an endoloop. After ligating its vasculature, the affected moiety, the affected pole parenchyma can be removed with a robotic monopolar curved scissors. So this dysplastic segment is freed circumferentially before to its division. The last step is the extraction of the specimen. The whole resected moiety can be removed through the trocar or through a small muscle splitting incision in iliac fossa. At the end of the procedure, we left always to drain is, but there is not mandatory, is left for 24 hours inside. Now I want to show you a short movie that show the procedure, the mobilization of the splenic flexure of the colon, the opening of the white line of Tolles, the identification of the lower pole of the kidney, left kidney, the open of the fascia, Gerota's fascia, to access to the kidney. Generally, it's difficult to identify the moieties, so it's more easy to identify and to try the both ureter. So you can see the dilated ureters and the normal. Now the management of the upper moiety. This is the check of the upper moiety, the isolation of the blood supply, and we use these vessels by clip appliers, 5 meters clip appliers. Artery was clipped and divided. But it's possible to use the bipolar forceps small vessels, as in this case for this vein, the coagulate of these small vessels. So we proceed with isolation of the proximal ureter of the upper moiety. So we isolated the proximal part, the hemostasis, and after the management of the distal part of the ureter, that in as long as possible is divided, is resected. You can see the hemostasis. Once cutted, in this case, we ligated the stump, the distal ureteral stump, by a Lendo loop, and now we pull up and pass it under the lower pole hilum, and pull up the dilated ureter to proceed and in order to coagulate the posterior vessels of the involuted moiety. Now, with scissors, diathermic scissors, robotic diathermic scissors, we circumferentially resect the polar, the upper pole, the upper parenchyma, and until to complete the totally resected of the upper pole parenchyma. You see, very easy by the robotic instrument to proceed to the resect. You see the last step, so the extraction of the specimen through the accessory port, 5 mm accessory port, but when it's large, it's not possible to extract by accessory port, and is requested a small incision in iliac fossa. We left always the drain for 24 hours. These authors, this is a paper that reports a collective summary of outcomes in robotic assisted laparoscopic partial nephrectomy. This is a review And these authors report a success rate of 100%, the complications rate that ranged by 10-20%, and operative time sometimes very long, 80 minutes until 450 minutes. But this time the authors say that decrease with the experience, with the learning curve. In the postoperative, the feeding of the patient restart 3 hours after surgery. The discharge of the patient 24 hours later after removal of the bladder catheter and the abdominal drainage. Regarding the follow-up, the Doppler renal ultrasound can be useful to confirm the intact blood supply to the normal moiety, and eventually a DM-safe renal scan to document a function in the remnant in the health moiety. Regarding the adverse events, we saw the wonderful presentation of Professoressa Ricci Petitoni. So regarding related to the procedure, the traction injuries to the vessels supplying the normal moiety, or the injury due to a spread of thermal energy, and the accidental injury due to the complex vascular anatomy. And as Professor Ricci Penitoni said, to avoid is very useful the segmental arterial mapping after intravenous injection of indocyanine green, and the remnant stamp syndrome. To conclude, the robotic-assisted laparoscopy, when disposable in the center, in the hospital, is an option for partial nephrectomy and may become the minimally invasive treatment of choice. The enhanced the visualization and dexterity of the robotic system potentially offer improved efficiency and safety over standard laparoscopy. And this procedure is an efficient procedure in the management of poorly and not functioning moieties in duplex system. And regarding the operative time, very long at the beginning of the experience due to approaching of the robotic system, the docking, the docking and the docking, and to decrease with the experience and with the skill of the surgeon. Thank you very much for your attention.
Thank you, Tommaso. From the audience, there is a question? No. And now I call the treasury of
La
international.
professoressa Ricci Petitoni.
Excuse me, I don't see the video. No. Giovanna, please.
Thank you, Tommaso. You did a really well extended presentation on robotic approach and steps. I agree with your conclusion that robotics will be the gold standard in the future, because you can do very well, you can see better, you can move better, and you can do faster too. Because if you do a lot of this procedure, you can do very, very quickly. I can say in this way because we have in Pavia a general urologist who used to do a lot of oncologic surgery and also sparing surgery, and he is able to do in less than 1 hour. So I think that we can learn and become faster. Then I want to just to say you that we have changed the trocar placement, starting from pyeloplasty, because the setting is the same. is the same. And we moved from auxiliary trocar to four trocar technique. Three on the same line, one a little bit displaced toward the iliac fossa, is much more easy, and more comfortable, because sometimes the accessory trocar is difficult to be moved, and you go faster this way. So you can try.
Yeah, thank you for this comment. Thank you, Professoressa.
Thank you. And now I ask to Alfonso Paparella, that is the Thesaurer of the Howard Group.
Thank you. Thank you, Mario. Thank you to Scientific Committee. I am going to share my screen with just two slides. And here we have this is the famous right now treasurer corner that was introduced right in the last meeting that we have. Just for, I want to remember our mail, that's Pediatric Life Surgery Group gmail.com. And this is my mail, my personal name. So if you have any question about the fee to to go inside for inscription to the group, you can call me, you can write me, and I will be very glad to explain everything. So I just want to stress the importance and the reason for joining the group, and also the reason why the fee is very important. As you know, the fee is very, very low. It's just 50 euros. So this is always very important, and it's essential to recognize that the support of all the members is crucial to continue funding the organization of surgery session. As you know, like in this morning, we have connection with many centers also in all the Europe and all around Italy. And so therefore, it's very important to sustain this initiative that will be very, very important to organize. And also we asked to all the members to renew the fees. So many of you have already received before an email containing the bank account number for submitting your fee. So just you have to take a moment to make the payment and just to give your tribute to sustain the group. So I think that it's really an incredible value, and I present this value to all the members. I think that it will be fine if you want to join us and sustain the group again. So thank you very much for your, and also I want to be in connection also with the Mirko, so we can make also just a point of something with the LinkedIn a connection for the treasurer corner, so we can organize also that corner in the LinkedIn to remember to the members of the group for the payment of the fee. So thank you very much for giving me this opportunity, and congratulations for this very, very nice meeting.
Thanks, Alfonso. And now, last but not least, Simone D'Antonio present two clinical case, particularly clinical case. Please, Simone.
Good afternoon. Thanks, Professor Lima. I'm going to share my screen. Okay. So, good afternoon to all the attendants. I'm going to present you 3 cases treated in our department in Bologna. The first case is a female born in our hospital with a prenatal diagnosis of a dysplastic cystic area of the upper pole of the right kidney. The first postnatal ultrasound confirmed the diagnosis and showed a prevalence of the right kidney over the left one, with multiple cystic formation of the upper pole in a probably duplex system. The cystogram was negative for reflux or other anomalies, and the DMSA renal scan revealed a mild hypofixation of the contrast at the upper pole of the right kidney. The UMRI confirmed the initial diagnosis and didn't find any other anomalies. We repeat another ultrasound at 5 months of life, and the situation was quite similar, a cystic dysplasia of the upper pole of the right kidney in a probably duplex system. So, due to this condition and to avoid impairment of the remaining healthy right kidney, we scheduled the patient for a right upper polar heminephrectomy by a video-assisted approach. And these are the pictures from the surgical procedure. As you can see, all the cystis of the upper pole of the kidney, and the final histological examination revealed a multicystic renal dysplasia, so not quite equal to the previous diagnostic suspicion, but we preserved more than half of the healthy parenchyma of the kidney. The second case is another female referred to our hospital from another center with the prenatal diagnosis negative for any urological malformation. And she underwent 2 hospitalizations in another hospital for febrile urinary tract infection and abdominal pain at 5 years of age. The first ultrasound showed a left kidney marked medially by an anechoic formation that continues until the bladder trigone, with the suspicion of a megaureter. The second ultrasound raised the diagnostic suspicion of a complete left duplex system with dilatation of the upper pole ureter. The cystogram was negative for reflux and ureterocele, and even the diuretic renography with MAG3 was negative for any urinary obstruction. She underwent a cystoscopy, not in our hospital, but from the original hospital, and they didn't say any ureterocele on the left side, but 2 left ureteral orifices, one in orthotopic position and another one ectopic towards the bladder neck. So the patient was referred to our center, and we complete the diagnostic workup with the UMRI that confirm the diagnosis of a left complete duplex system with a severe dilatation of the upper pole urinary tract. At this level, no cortical perfusion and no pielo-ureteral extractory phase are evident. So with this kind of situation, we opted for a left upper pole heminephrectomy with proximal subtotal ureterectomy. In these pictures from the surgical theater, you can see a very huge dilatation of the urinary tract and the performance of the upper pole heminephrectomy and ureterectomy. Last case is a male born, the more complicated case, born in our center with a prenatal diagnosis of a severe right hydroureteronephrosis and ureterocele in a suspected duplex system. The postnatal ultrasound confirmed the diagnosis and showed a bilaterally dilated ureters, so even on the left side. The cystogram was negative for reflux, for any urethral malformation and any filling defects, such as ureterocele, and the bladder was described as a predominantly longitudinal development. We continue the diagnostic workup with the URMRI that didn't show any clear visualization of the meatal ureter outlet of the right upper pole ureter, raising the suspicion of a blind ending ureter in the retrovesical space. And even the right lower pole ureter in its terminal part was compressed between bladder anteriorly and right upper pole ureter on the posterior face. And even the MRI showed a dilatation of the left ureter. In our opinion, the left dilatation was caused by the compression of the huge right urinary tract dilatation. The DMSA renal scan showed an hypofunctioning right upper pole kidney versus the lower moiety, and the patient underwent a cystoscopy, and the cystoscopy was negative for posterior urethral valves, and we saw two right ureteral mitosis, ectasic and lateralized despite the bladder trigon. Unfortunately, this patient presented several episodes of urosepsis in the first months of life. And so, according to the results of the diagnostic exams and patient clinical history, we opted for a right upper pole heminephrectomy and partial ureterectomy. These are the pictures from the surgical procedure, and nowadays the patient is in follow-up, and he didn't have any episode of urinary tract infection. Thank you.
Thanks, Simone, and I open the discussion. If you have some answer, some question. Okay, thank you, Simone. It's very clear. And now
Professor Ricci Petitoni, maybe.
I don't see. Your hand is very small.
No, I try to maintain a discussion. So, congratulations, Simone. I have a question regarding the first case. So it's very peculiar to have a multicystic kidney in an abortive double system kidney. So my question is, did you check for the ureter? Did you perform a cystoscopy to see if there was one or two orifices? You know, one of the cases is the agenesis of the ureter. So probably the ureter was not there, but it's just a diagnostic question. So did you check for the ureter, the upper dysplastic pole?
Thank you for the question. We didn't perform a cystoscopy, but we based it on the URMRI that was really clear, and even intraoperatively, we have a clear situation of the renal pelvis and the first urinary tract, and so we are confident that it was an abortive, a partial multicystic kidney, according to an abortive maybe duplex system or a near etiopathological condition.
Thank you.
I want a comment on this. When you have a double system, I think it is mandatory to do the cystoscopy before, because it's ideal for identifying the good ureter and have sometime a tutor in the good URL. And this is important because during the surgical procedure, we don't have problem. Well, now we are finished. I asked to the Vice President, Holger Thiel, if you want to close this meeting. And the appointment is the 18th of June, with the argument is duodenal obstruction and malrotation. Please, Holger.
Dear all, dear Giovanna, dear Mario, especially, thanks to all the presenters. Thanks to sometimes over 100 participants appreciating our setting. I think the idea, the concept from Professor Mario Lima many years ago is a big success today and so in the future. So please stay with us, join us for the next meeting. And it has been a pleasure again, Mario, to be part of your team. Thanks.
Bye.
Thank you, thank you. And have a very holy, special Easter.
I see you all in June, the 18th of June. Bye. Bye.
Bye.
Bye, Giovanna. Bye, Alfonso.
Grazie, Mario.
To all of you, and good Easter. Have a good Easter.
Ciao, Giovannina.
Ciao, ciao.
Grazie mille.